So I'd like to introduce Andrew Webster, who's from Perth, who's a respiratory and sleep physician who's trained in Adelaide, Sydney as well as Perth, and he's going to talk to us now about the consequences of untreated obstructive sleep apnoea.
So I'd like to say thanks very much for first asking me to come along, and just to say it's been a fairly broad topic, so there'll be some fairly disparate topics that we'll be kind of talking about, and some of them will be more familiar to you, and hopefully some of them will be fairly new. So we'll just... So really want to summarise the data on the impact of obstructive sleep apnea on cardiovascular and cerebrovascular diseases, as well as metabolic diseases as well. In particular, we're really going to be talking about diabetes for obvious reasons. And then moving on to perhaps areas that people are less familiar with, which is the neuropsychiatric conditions, particularly depression and more recently PTSD, of which there's been a lot of in the literature about, particularly over the past, well, 6 to 12 months, I suppose. And then societal consequences, so that covers the kind of usual motor vehicle accidents, absenteeism, etc. And then a brief part on adherence. So this is fairly axiomatic and everybody knows this, but we'll just summarise. So the OSA is associated strongly with a number of cardiovascular diseases, namely hypertension, ischemic heart disease, stroke, heart failure, and arrhythmias, particularly AF. Now, depending on what the cut-off for the AHI is used, it will depend on the relative prevalence of that particular condition. So here represents if the AHI is, let's see, if it's greater than 5, then the prevalence would be 83%. And then if the AHI is 15, then the prevalence would actually go down to about 30%. And this basically is across the range, but hypertension would be seen most commonly. Now, this is just a brief slide, and once again, people know this, but it's just to clarify a few points, particularly related to things along the lines of effects of good adherence. Now, BP improvement is expected in patients with CPAP therapy, and the effects are correlated, not necessarily linear, so with OSA severity, baseline BP, and once again the hours used. And as we know, that the kind of magic hours used is, or cut off, is 4, whether that's right or wrong, and we can come to that later on. And also in resistant hypertension. And here we've got linear reductions in BP with increasing hours of CPAP, and for every BP decreases 1.9 and 1 millimeter in systolic and diastolic BP respectively for each additional hour of CPAP usage. Now, just to put this into perspective, this is on par with what you would see with known antihypertensive agents, and it can confer a reduction of 4 to 8% reduction in the future risk of stroke in coronary artery disease. And I think if I recall that the adherence rate of somebody taking an antihypertensive at 1 year is not really that much better than somebody actually using CPAP at greater than 4 hours. So it's just something to bear in mind. Now, these are from the recent guidelines from the Journal of American Cardiologists. It suggests that treatment of OSA with CPAP reduces BP, sorry, that should be in patients, and nocturnal BP and treatment-resistant BP. The effect of blood pressure is less effective on mild hypertension, and particularly those without excessive daytime somnolence. Now, once again, just to reiterate, sorry about the long sentences, despite the solid reduction, a decrease in only 2 millimeters is enough to produce a clinically significant reduction in CF, cardiovascular risk. And we can just kind of skip over that there. So it must be attributable to limited ability to reverse vascular pathology. So just to say as well that most studies actually cut off, they don't go past one when they're looking at effects of CPAP on BP. They don't go past 1 year, and there is the suggestion that there is a further reduction past 1 year. So, but nobody's ever kind of done the study past that. Really it underscores the notion that early and prolonged treatment is required. Now, just moving on to diabetes, and once again, we found that untreated OSA is associated with worse glycemic control, and this was actually from a state-of-the-art paper in Chest of this year, and it's well worth reading. There's too much in it for obviously to summarise. And here, if you've got no OSA, that's your average GHI, and then you get this incremental rise, and this is independent of obesity. Right. So, and just to say that there's been multiple studies over the past 5-10 years or so looking at the effects of CPAP therapy on glucose control, insulin sensitivity, and there has been fairly consistent results that this can be beneficial. However, there's been a paucity of robust, decent studies to assess the effects of CPAP therapy on glucose control as measured by the HbA1c. Now, this paper was from August of last year in the Blue Journal, and this is probably one of the most robust ones. And for various for one main reason, I'll tell you why this is actually it's better designed. So they had 24 weeks, and they had 50 patients suboptimally controlled. So fairly not massive studies by any manner of means, but they found there was a reduction in HbA1c at statistically significant of HbA1c reduction at 6 months, and then most importantly in this group it was greater than 5.2 hours. And here's, you can actually see there, so essentially there was no difference in your HbA1c or reduction in the HbA1c as you went out to 3 months, and then there was a divergence from 3 months down to 6 months. And just to kind of put that back into perspective, when you're looking at say hypertension, drops in hypertension, and looking at the relative reduction in cardiovascular events. If you have this data here would be looked at from oral hypoglycemics, would be that a fall in 0.4 would confer an 8% decrease in cardiovascular disease and 15% reduction in microvascular complications. So that's just the long and short of it is good glycemic, good adherence to CPAP therapy can make a significant difference. So we'll just quickly fire through this. So in a 2011 meta-analysis, OSA increased the risk of recurrent AFs after radiofrequency ablation by 25%. So I'm sure most of you will have been aware of that one. And then this is just another one to put in and fill the page, which was a retrospective cohort of adults found that people with AHI of 5 had a statistically significant risk of developing incident hypertension. Now, this once again is actually to stress the importance of adherence. So this was from back in 2013, so they took 720 patients who had just had pulmonary vein intervention, and then they stratified them according to whether they had untreated obstructive sleep apnea. By untreated, they meant anybody who was on CPAP therapy but who fell below 4 hours. So technically, they weren't untreated, they just had suboptimal treatment. And then they had all sleep apneas, and then treated sleep apneas, and then no sleep apneas. And that was essentially the graph showing that the AF recurrence rate and the difference between untreated and treated and treated. And so the recurrence rate of AF, the hazard ratio was, so you're 2.79 times more likely in the untreated group to have recurrence of AF than in the treated group. So we'll just skip through this one, but this is obviously related to, I think this was the kind of seminal study looking at stroke, and we didn't bother showing the Kaplan-Meier curve, but this was from the sleep heart health study, and showed 8 years of prospective data, and it showed that it was actually men were at 3 times more greater risk of having stroke than in men, and in women it was only the case when the AHI was greater than 25. Apart from men, it was across all AHIs and severities. Now, when we're just talking about the impact of stroke on neurological recovery after ischemic stroke, this was a very small study just to get an idea of other effects of OSA on cerebrovascular disease. This was a study that was published about 3 months ago, actually, and it was a prospective single-centre study, and they looked at the prevalence and severity of OSA with acute ischemic stroke, and it was really to compare neurological and functional outcome with and without OSA, and they found that so people had presented with stroke, they all had polysomnograms, and 60% of them had evidence of OSA, 25% had severe OSA, and then what they did was, I'll just move to the next slide. So this measure down here, that's the kind of standard measure as to disability and severity of stroke when people come into hospital based on visual field defects, weakness and such like. And this MRS scale, which is the scale up here, that's a measure of functional limitation, right? So when you come into hospital, which is here, and you're looking at the function, this is the kind of neurological deficit. There's a statistical significant between the OSA group and then the non-OSA group, and that continues until the point of discharge. And once again, less so when at point of admission, so there's reduced recovery in terms of functional improvement over the period up to 3 months, and then essentially it starts to improve, but once again there is still a statistically significant difference. Now, just briefly, now I have to profess I'm no kind of expert in this area, so people are to ask me questions or clarify things at later on. So prevalence of PH with moderate to severe OSA is approximately 20%, and it's important to confirm the presence of PH in patients with OSA primarily for 3 reasons. Because OSA is associated with higher mortality amongst patients with and without PH. It's also associated with reduced quality of life, and the treatment modality specific to OSA should be formulated. And there's also the possible coexistence of another etiology of PH that needs to be discerned. And finally, last one we can just go through is that the pH tends to improve with the treatment of OSA, but not necessarily completely. And the greater degree of pH, second primarily because of the OSA, the greater response to treatment, as is usually the case for other treatments. Okay. So the reason we just put in, this is also a trial that just highlights the issues to do with compliance and subsequent outcomes. Now, this happened from the Blue Journal last year, and it was a single centre, with non-sleepy moderate OSAs and ischemic heart disease. So these were the kind of people that you would have seen perhaps in the SAVE trial. And it was a single endpoint, which was first revascularization, and the median point was 57 months. And the endpoint was 18.1% in the CPAP control group and 22 in the control group. Now, after they actually looked at the compliance of greater than 4 hours a night, they actually found out that there was a statistically significant difference in improvement in outcomes. And once again, you could see that with the one with the study with the atrial fibrillation and a few other ones. So we won't necessarily go into the SAVE trial, but there's been 3 meta-analyses looking at the effects of CPAP therapy and the prevention of cardiovascular events in patients with OSA, and they've all followed each other within the space of 2 weeks. What this came to the conclusion was that in less than 4 hours per night, they felt that there was no benefit in terms of cardiovascular outcomes, and then was greater than 4 hours that there was an improvement in outcomes. So those are my faces. That wasn't in the gym. So this was the conclusion from the meta-analysis and the subsequent one as well from the American Heart Journal. And their opinion was that in moderate to severe OSA, CPAP compliance for the duration of 4 hours may reduce the risk for major adverse cardiac events, and it was driven primarily, once again, by stroke, and then obviously compliance, etc. And without a doubt, mood, daytime compliance, absenteeism, etc., which was seen in the SAVE trial, was not disputed. So, the next part, just briefly, is that OSA increases the relative risk of motor vehicle accidents by approximately 2.53, and that paper, I think my mistake was actually from Thorax, going back approximately 2001, and there was a Japanese paper recently that said if your AHI was greater than 60, that you had an increased risk of motor vehicle accidents by about 6 times. So, and just to say that whilst everybody kind of focuses a lot on cardiovascular diseases and effects of CPAP, that morbidity and mortality in motor vehicle accidents and obstructive sleep apnea is actually similar to all of the cardiovascular sequelae. So it's just something to not to forget. And then they've also found that use of CPAP therapy reduces the risk of MVAs by I think it's 72%, and that was from a Swedish study from 2015. So once again, just to bear in mind that this was from the Sleep Health in 2017. Workplace accidents increased by 1.5. We also had absenteeism, and it was actually at 9.8, which I thought was quite high. And there was also interpersonal conflicts, which presumably whether that's related to irritability, mood disturbances, and that kind of thing, which we can come to later on. And reduced job satisfaction. I think burnout was actually high up on the list as well. And really reduced quality of life once again. So all of these, the quality of life was mentioned, depression was mentioned, and absenteeism was once again mentioned in the SAVE trial. Right, so this is an important paper. Well, I thought it was anyway. So this is from Professor Hillman's group over in WA, and this essentially was looking at the effects of depressive symptoms before and after sleep apnea in men and in women. And they took 426 patients who referred to the Centre for Evaluation of Suspected OSA, and then depressive symptoms, as opposed to markers of depression, come to that in a sec, were assessed during the validated PHQ-9 score. So just in case people aren't necessarily that familiar with the score, it's been validated for 1, screening, and 2, measuring effect of treatment over a period of time. Now, the specific one is on question 9, so there's, you have the question is, how often do you feel that you would be better off dead? And there can be either never, sometimes, some of the time, or quite a lot of the time. So, and then essentially they had their sleep studies, they put them on CPAP therapy, and they had compliance of greater than 5 hours a night. And that was about for 3 months. And what they found was, at 3 months, there was a significant depression symptoms in only 4% who had adhered to CPAP. Now, the really important thing here, or the surprising thing, was that of the 41 adherent patients, right, who reported yes or frequently to question 9, none of them reported persistent suicidal thoughts. So that was, and the inference from this is that certainly for things like general practice and all the rest of it, is that people used to think of patients coming up with OSA of tiredness, lethargy, fatigue, but now there's this kind of crossover into what we consider to be frank, or previously thought to be frank psychiatric symptomatology, i.e., wishing they were better off dead. So that's just. Now, this one's just interesting, and people will think it, not necessarily think of it immediately, but currently 8.5 million Australians have some varying form of post-traumatic stress disorder, so it's not small. It's actually one of the most common mental health problems, obviously, in certain populations, women, refugees, and that kind of stuff. And the other thing to mention is that of all certainly psychiatric conditions, there's the highest prevalence of 79.5%, right? So there's a synergistic relationship between obstructive sleep apnea and PTSD, and if you want, we can talk about that later on. And just as a little side note for interest, the people who have got the highest incidence of prevalence of PTSD were people that came out of the World Trade Towers, because what they felt was that they had actually inhaled gas and particulate matter, which affected other upper airway, which increased the propensity for it to collapse. Now, there's good evidence that CPAP therapy reduces nightmares, right? And that's fairly standard, Now, I actually just thought this was kind of interesting. This was published about 2 months ago. Now, it shows that improving PTSD symptoms actually prevents progression, or there's evidence to suggest that there is progression, of subclinical PTSD to overt full-blown PTSD by treating it with CPAP therapy. So the mean PTSD checklist is by a thing called the PCL, but we'll need to go into that. So if you have a drop in 5, then it's considered to be a clinical significant reduction. So this was the mean PTSD, this is across all groups, was 66 down to 61, and that was deemed to be significant. And also, once again, nightmare frequency. And like I said, nightmare frequency it's fairly obvious that it would fall. Now, this again is to highlight issues of compliance. So these are subscales. So depending on the PCL-9 score, so you've got the intrusion score, right? So these are the quartiles of CPAP compliance, right? So that's the first one, second one, third one, and fourth one. So these are the people who have got full-blown PTSD. So see that one. So if you're in the first quartile and you use it, you get a degree of response. If you use it in the second quartile of OSA adherence, then you get a subsequent improvement or a greater improvement. And then if you use it even more, you get a really significant improvement. Now, and once again, you can see that here and here and here and here. Now, if you look at patients who have, let me see, where are we? Non-PTSD, or the sub-threshold PTSD, is that if you're in the realm of only using it within the first quartile, you actually get worse, because if it's lower, the more lower the line essentially means progression. And then again, if you use it in the second quarter, then you still progress, but probably not so much. And it's only when you use it in the third, this is for arousal, do you start to get any form of benefit. So what it's saying is that in order to get benefit in the sub-domains of the PCL score, you need to have greater degrees of adherence in the non-PTS, the subclinical PTSD group. And I just thought I'd like that, actually. If somebody wants to read that article, it's fascinating. I know nothing about Freud, by the way. I just thought I'd put that in. Like, nothing. I think analyse this, analyse that, with Robert De Niro was probably on it. Right. So this is just a bit of physiology, basically, just to kind of lighten things up a bit. So this is called the neural blueprint of obstructive sleep apnea. So the hallmarks of obstructive sleep apnea are pharyngeal obstruction, and then we've got intermittent hypoxia, sleep fragmentation, and this part here is the part of the brain called hippocampus, which I'm sure from your neuroanatomy days is the part of the brain that is most exquisitely sensitive to recurrent episodes of hypoxia, and it's responsible for, hippocampus is responsible for memory formation, memory retention, memory processing, and also emotion. So, and then CPAP comes in here and ameliorates the effects to a degree. Now, this is just, it's probably kind of get off tee, but I thought I'd put it in anyway. So this is obstructive sleep apnea, and there was brain structural changes and neurocognitive changes before and after treatment. Now, essentially what they did, they took a small number of patients, I think there was about 30 or 40, but it was the first paper of its type back in the Blue Journal, and they took patients with severe obstructive sleep apnea, and they put them on CPAP therapy, and there was good adherence during that entire time. And then they measured the volume of the hippocampus and correlated that with neurocognitive function. So that's just an example. So that was the volume and activity on the hippocampus. That was pre-CPAP, and that's post-CPAP. So from the demonstration was that represented a more active area with regeneration of cells there. And now what they found was, this was a bit difficult to interpret, but as time goes on, you've got, it's difficult to see that, but that's one part of working memory as time goes on, and the other part of other memory actually improves as well, and this area represents increased hippocampal volume. So we've also got sleepiness is an important factor in neurocognitive impairment, and they feel that with excessive daytime somnolence causes problems with inattention and vigilance, memory and executive function. What they found is that treatment with CPAP therapy only improves cognition and memory in patients with OSA if they have sleepiness at the start. So if they don't have necessarily sleepiness per se, if they have tiredness, lethargy and fatigue, they don't improve in terms of their memory. So excessive daytime somnolence is the prerequisite. Okay. Now, this is another one just to kind of mention about cognition, was they found patients with mild to moderate Alzheimer's disease based on the mini-mental, and it was a single-blinded trial, and it was a 3-year follow-up, and they found that the mini-mental decline, as opposed to improvement, was significantly slower in the CPAP group than the non-CPAP group. Oh, right, okay, sorry. So, and that's just a little graph there. So that's the CPAP treatment group, and that's the non-CPAP treatment group, and that was over a period of 3 months. So essentially it's, yeah, okay. So really, we're getting into the kind of take-home messages, if you want, from the cardiovascular, and this shows that CPAP therapy does lower blood pressure and can improve insulin sensitivity. Good adherence to CPAP, which we've seen all the way through from start to finish, prevents instant hypertension and can improve other even cognitive outcomes, and it can reduce the occurrence of adverse cardiovascular patients with moderate to severe OSA, and patients. This was from one of the meta-analysis, should not expect to lose weight. And then finally, secondary prevention is that CPAP improves office BP and nocturnal BP, and patients with previous cerebrovascular or coronary vascular disease, CPAP therapy does not necessarily improve survival. However, that is, I suppose, there's a bit of debate in that, perhaps another time. And if there is a risk of, if there is a reduction in mortality, then it would appear to be driven by reduction in stroke. And nevertheless, it's not necessarily to say that we shouldn't treat people with CPAP or mandibular advancement splints for that matter, or anything else. Mood, productivity, CPAP, and also neuropsychiatric conditions. And that's that. Okay? And then you can go into adherence. Is that okay?